Hello everyone, I'm Ellie, and tonight's session will be taught on general surgery, and this is part one of two sessions that we're going to run on just a variety of general surgery topics. I'm working as an F2 at the moment, and I'm down in Exeter in Devon, and if you want to follow us for any more teaching sessions, if you follow our link there in the top right hand corner, that will take you to our Instagram page. And any questions that you have for us, or if you want to get involved in any teaching yourselves, then the link to email us is down in the bottom left there. So this evening we'll be using VBox to go through the questions. So if you want to scan the QR code there, and it will let you log in, and then as we go you can vote on answers to the short single best answer questions. Okay, so just firstly, the main sort of area that we're going to cover tonight is acute abdomen style presentations. So acute abdomen is a term used to describe sudden onset severe abdominal pain, and it encompasses a wide range of underlying conditions. So to try and localise what condition you might be looking at, a good pain history from the patient is essential. So think about your Socrates acronym. And the area of the abdomen predictably corresponds with the underlying anatomy that's affected. So here are your abdominal regions and broadly what is underneath. So you might see this sort of cartoon abdomen drawn in ward round notes, for example, just a little hexagon with quadrants drawn onto it. Some people divide the abdomen into four, but for the purposes of this lecture, we're going to divide it into these areas here. So on your right upper area, you've got your biliary system, your liver. Also important not to forget the lower lobe of the lung as well, because sometimes a pneumonia or an empyema in the base of the lung can cause pain in this area. The right flank, you've got things like the kidney, cecum, and overlying small bowel. Small bowel, pretty much, as you can imagine, is felt across the whole of the abdomen. The right lower quadrant, we've got things like the appendix. Again, the cecum can sort of pain can be felt in that area, and also things like ureters and ovaries. In the epigastric area, we've got things like the pancreas, part of the stomach, and the GOJ, and the transverse colon. Umbilical area is lots of bowel. Suprapubic area, you have things like the bladder and the uterus, and on the left side, left upper, we've got stomach, and don't forget about the spleen. Left flank, the kidney, descending colon, and again small bowel. And then left lower area, we think about the sigmoid colon, ureter, ovaries again, and don't forget about the groin areas for any hernias, particularly when you're examining someone's abdomen. So just some important definitions to remember and go over. So if a patient is guarding, that is when they involuntarily tense their abdominal wall when you press on that area. And that's a sign of something going on under that spot. Rebound tenderness is pain that is worse when you release your hand rather than press your hand. Localized peritonitis is an area of inflammation that's associated with one particular part of the underlying anatomy. So for example, in appendicitis, you can get tenderness and guarding in the right lower quadrant, particularly if you've got inflammation of the surrounding peritoneum. And then a generalized peritonitis, we're thinking about the hard distended abdomen with generalized tenderness, and it's often indicative of severe underlying pathology. So for example, a perforation of a viscus. So our first question tonight, so a 45-year-old woman comes to A&E and she's got severe pain in the right upper quadrant for the last 2 days. She feels nauseous and she's not visibly jaundiced. So they're her observations. So what is the most appropriate first-line management for this lady? Give you a couple of minutes to answer those. Okay, so answers
Sorry, is there anybody else having screen problems? We've got one student who said the screen's disappeared. I can still see it. If there's anyone else in the chat, if you can just say if you can see it or not. Got a thumbs up, so I think that means it can be seen. Hopefully,
okay.
it might just be worth sort of opening and closing if you're using your app or something to that person.
Okay. All right. Yeah. So if any problems carry on, just let me know again. I can always stop sharing and reshare. Questions wise, have we got where have we got most of our answers?
Majority have gone for D.
Fantastic. Yes, it is indeed D. So this lady, what I'm angling at here is cholecystitis. So classic presentation of cholecystitis is right upper quadrant pain, nausea and fever. And possibly if it's left untreated or it's very severe, it can progress into sepsis. So remember that cholecystitis is, it's caused by an infection in the gallbladder, and this is usually due to stasis of bacteria due to an obstruction by a gallstone. So your gallstone blocks the neck of the gallbladder. Bile can't drain very well, so you get this sort of stasis of bile that can't drain away, and that encourages bacterial growth. Investigations, first line, obviously we do bloods, looking at infection markers, and LFTs as well is really important because it gives us an idea of any impact on liver function, and we can, when someone's in hospital, we can take blood to sort of follow the trend. Are they improving and are we getting on top of things? Ultrasound abdomen is the first line investigation that we use, unless we suspect that someone's septic or they might have perforated, in which case a CT would be more useful. And management for these patients is usually admission. I have seen occasionally, if it's a person who's younger and very fit, and their pain's not too severe and their bloods are kind of, not terrible, sometimes they will send them home with oral antibiotics, but there's a really, really strong safety net there for people to come back if they're not improving in the next sort of 48 hours. So usually anyway, we admit the person, stop them on IV broad spectrum antibiotics, and then ideally NICE recommends a cholecystectomy within 1 week of diagnosis. That's obviously if they're well enough to undergo surgery, and if they're not, we can drain percutaneously. Obviously, if they're septic, they may also need ITU. And then just briefly mentioned about Murphy sign as well. So that's a term that you might hear, and that means pain when the patient breathes in when you're palpating in the right upper quadrant. And then also to think about in the right quadrant, we've got ascending cholangitis. So patients with this condition will be very unwell. The typical triad that they ask you about in exams is fever, jaundice, and right upper quadrant pain. And ascending cholangitis is caused by infection that ascends up the biliary tree. And again, it's usually due to a gallstone stuck somewhere in the biliary tract, but can also be due to strictures. Investigations, again, bloods, an ultrasound abdomen, or a CT if that's not conclusive. And the management is usually ERCP, so going in, doing an endoscopy, and then using a very small tool to go up inside the sphincter of body, up the biliary tree, and fish out the stone. And also we want to give the person IV antibiotics. Again, there is a percutaneous option if the person's sort of too sick to undergo an endoscopy, but it often requires ERCP afterwards for kind of long-term definitive management. Okay, so second question of the evening. So a 52-year-old lady this time, she presents to A&E with intermittent right upper quadrant pain, and she's previously had pain like this, but it's not been as bad. Pain is associated with eating large meals, and she's got hypertension, but she kind of controls this with lifestyle and takes no regular meds.
Sorry, Ellie, the slides haven't moved on.
Okay, that's fine. I will stop and reshare. Can you see them now?
Yeah, we can.
Lovely. Okay, so I'll start that question again. So this 50.
Sorry, I'm going to interrupt you again. It's like a vertical view, so you can only see like half of the slide.
Oh, I don't really know. Let's try sharing the whole screen. How about now?
Yeah, I can see it just got the teams. Yeah, there we go. Perfect.
Yep, lovely. Okay, great. So 52-year-old lady presents to A&E with intermittent right of quadrant pain. She's previously had pain like this, but it's not been as bad. The pain is associated with eating large meals. She has a history of hypertension, but she's not on regular medication and she controls this with sort of lifestyle measures. What would be the recommended first-line investigation for her? Okay, what sort of answers have we got?
They've got the majority going for D, but with some votes for A.
Okay, yeah, so the answer I was going to go for was D. I can see why we might say A, because you know, CT is sort of a general useful image, but what I'm getting at here is gallstones, and the best investigation for gallstones imaging wise is ultrasound in the first instance, particularly if somebody's not got any signs of sepsis. So this lady had the quite typical picture of biliary colic, so cramping episodes of right upper quadrant pain, and it's often associated with large or fatty meals. People can have repeated attacks, and they usually end up coming into hospital when they get an attack that's too painful for them to manage at home. But the difference between biliary colic and cholecystitis is that the person is not showing any signs of infection, so they're apyrexial. Their bloods, they may well have some slightly deranged LFTs, but their inflammatory markers are normal. And the pathophysiology is a stone that sort of becomes stuck in the neck of the gallbladder, usually. And as the gallbladder is kind of peristalsing and trying to move that stone along, that is what's causing the pain for the patient. So investigations, we pretty much always do bloods and then an ultrasound abdomen, or we can do an MRCP, so investigation of the biliary tree using MRI. Management of biliary colic in the first instance is conservative, so avoiding fatty food and large meals, trying to lose some weight, and then the plan really is an elective cholecystectomy. But you know, wait lists at the moment can be quite long. It's really important to give patients some red flag advice about what they need to come to hospital with, particularly any signs of infection, any jaundice, or pain that they can't manage at home. And you might hear about the 4 Fs in medical school, sort of a mnemonic that people use for risk factors for biliary colic, sort of age, being overweight, being female, or being sort of reproductive age. Okay, so question 3. So 35-year-old man is brought to A&E and he is collapsed at home with severe upper abdominal pain, and he's been getting more unwell for the last 2 days, and he's vomiting pretty much non-stop to the point where he looks quite dehydrated. So what is the most likely cause for his presentation? Okay, should we have a look at the answers for those?
So we have a three-way tie between A, B, and D.
Okay, great. So that's good actually, because we can explore those. So what I was going for was B in this case. I can totally see why people said A or D. So D actually I think would be quite a fair top tie. The reason we're sort of swaying in this case, so this is a pancreatitis presentation, but it could easily be sort of a viral gastroenteritis. The only thing that would lean more towards pancreatitis in this case is that the guy has come in after sort of collapsing at home, and he's just vomiting sort of constantly, which, yes, I guess you could get a collapse with a viral gastroenteritis, but it's unusual to be sort of collapsing unwell with that. Gallstones, yes, so gallstones is a top reason for pancreatitis. We'll come on to that in a moment, but he is sort of the wrong demographic, if you like. He's slightly too young, he's male, so it's possible, but not the most likely cause we're going for. So acute pancreatitis, a typical presentation is the severe epigastric pain, and it often radiates through to the back. It causes profuse vomiting. Patients don't want to eat anything because they're just in so much pain, and they're vomiting all the time, to the point where they're likely dehydrated. And people can have recurrent episodes of pancreatitis and go on to develop a chronic disease course. And the pathophysiology is really self-digestion of the pancreas, so a release of sort of exocrine secretions and an inflammatory response, and in severe cases it can lead to necrosis of the pancreas. Investigations that we would do: bloods, particularly lipase, which is actually the more accurate test to do, although a lot of hospitals still do an amylase, which also gives you an indication. Ultrasound abdomen is important if it's the first time someone's had pancreatitis, because we need to rule out that it's not being caused by gallstones. But after that, the most useful imaging modality is CT, and the management is first off conservative. So we replace any fluids, electrolytes. Sometimes people need artificial feeding, things like TPN, and of course lots of good analgesia. If they've got evidence of necrosis, so they're in hospital, they're not improving, and their inflammatory markers just keep getting worse, or they're showing sort of septic signs, then it's possible that they've developed pancreatic necrosis, in which case sometimes we go in surgically and remove the necrotic tissue. Complications of pancreatitis, most commonly is a pseudocyst. So this collection of sort of fluid and enzymes develops next to the pancreas, and it has kind of a mass effect on the surrounding organs, and it often resolves itself, but if it's not gone after 6 weeks, chances are it will need IR drainage. And then the term type 3 diabetes is becoming more commonly used now. And type 3 diabetes is basically diabetes secondary to destruction of the pancreas through pancreatitis. Alcohol excess and gallstones are the most common causes in the UK. And you've probably all heard of I Get Smashed, which I won't go over now in great detail. But people love to sort of pull out the scorpion card and things like that. Think about the common things first, particularly when you're coming into your exams. Okay, so question 4. So a 21-year-old is brought to A&E with severe abdominal pain, and the pain came on very suddenly in her upper abdomen, but it's now generalized, and she feels generally very unwell. And she's also got pain in her right shoulder. She's got no significant medical history, but she did have an ankle sprain 4 weeks ago, and she has been taking sort of analgesia that she's buying for herself for that. So the observations are there. So what do you think is the most likely cause for this presentation?
Okay, we've got the majority going for C.
Okay, brilliant. Yeah, so C is the answer I was going for. So this was based on a patient that I saw in F1. So it's actually somebody that had a young patient who had overused NSAIDs without gastroprotection and ended up with a perforated ulcer and was very unwell. So although it's not a common presentation in and of itself, it is something to consider, and particularly getting a good history about sort of medicine use in the last few weeks. So the presentation of a peptic ulcer is kind of a burning epigastric / left of quadrant pain. And a gastric ulcer is typically, the pain is exacerbated by eating, because if you imagine the food is in the stomach, you know, digestive enzymes are being produced, and that's irritating the damaged mucosa. And during that time, the sphincter is closed, so the duodenum is kind of protected. So that is why a duodenal ulcer, the pain is relieved by eating, but then it's worse 2 to 4 hours afterwards when that sphincter opens, and the sort of digestive, the food and the enzymes are passing through. Pathophysiology is the breakdown of the gastric mucosa, and it's often due to infection or inflammation. Investigations that we do, the most useful is an OGD, and then we also want to test for H. pylori, which we can do while we're doing the OGD, or we can do breath and stool tests as well. And that's particularly useful in younger patients where you don't necessarily want to subject them to an OGD, but they've got kind of grumbling gastritis type symptoms. Management of peptic ulcers generally, so first line is conservative, managing diet, avoiding things like spicy food, alcohol, and stopping smoking. And if they've got H. pylori, we can do obviously the eradication therapy, so 2 antibiotics and a PPI. If they haven't got H. pylori, but they've got kind of gastritis symptoms, often GPs will try 4 to 8 weeks of PPIs if there's no red flag symptoms and see if that improves things. If it's an emergency, so they perforate a peptic ulcer, they do something called a Graham patch, which is literally a patch over the hole. And think about perforation in a patient if there's risk factors for having that. Red flags that require someone to go and have an OGD as a 2-week wait include being over 55 with new dyspepsia and weight loss. And once we've done the OGD, we do recommend that gastric ulcers generally are biopsied, because sometimes in cancer, sort of the rolled edges of an ulcer can look very similar, whether it's benign or malignant. So just to rule that out, they tend to biopsy them. So we're just over halfway now. So question number 5, the 75-year-old man comes to A&E with severe generalized abdominal pain, and he's not opened his bowels for the last 4 days, and this morning he vomited some dark brown liquid. He appears frail and underweight. On examination, he has localized tenderness in the right flank, but his abdomen is generally soft. What is the most appropriate first management step for him?
Okay, so we have a 50% are going for D, 25% for C, and 25% for A.
Okay, so again, it's like a good spread of answers, and I can totally see why we've got that. So the first management step, I would argue, would be A. So, I mean, honestly, you're going to do most of these things, and I suppose order might not come down to it. But the reason I went for A as the first thing, if this guy has got to the point where he's vomiting, there's a real risk of him getting sort of an aspiration, an aspiration pneumonia from what he's bringing up. So to protect his breathing, and if you think of sort of the ABCD approach, really we want to get that RAS tube in and offload some of that fluid to try and prevent that risk. Because once someone has the aspiration pneumonia, it's really, really nasty. IV fluids would definitely be a close second, because it's going to be really dehydrated after that. And then he's going to need a CT. It might well that he needs B. I'd say E is probably the only thing that we might not do in this gentleman. So there's obviously other causes for right flank pain, but this case was angling at colorectal cancer. So often this presents insidiously, so with things like weight loss, unexplained iron deficiency anemia, reduced appetite, but quite often, I think it's about a third of cases, patients can present in an emergency, so an obstruction. And the pathophysiology of most colorectal cancers is the normal mucosa to adenoma to adenocarcinoma sequence. And risks include family history, low fibre diet, a history of IBD, and being older. Right-sided tumours often present late because patients don't get typically sort of blood in their stool. Symptoms are sort of more subtle, whereas left-sided tumours give more symptoms like bleeding or tenesmus, which is a feeling of needing to pass stool but not actually being able to. Once someone starts losing weight, it's a strong indicator that they've got metastatic disease. So first investigations for this gentleman before we know his diagnosis would be bloods, a CT. If a CT showed a lesion there, we'd need to do a colonoscopy and get some biopsies. And that's really important for the histology and thinking about what treatment we can give him. And dependent on the stage of the cancer, we might think about resection for a tumour, plus or minus chemo to shrink the tumour before we resect it. Or unfortunately, if disease has progressed to the point where it's not curable, we might think about sort of chemotherapy, but not with curative intent, so palliative approach. And then just a broad overview of bowel resections. Obviously, you could do a whole lecture on this topic sort of on its own. But right-sided tumours, the general approach tends to be a right hemicolectomy, or it can be an extended operation if there's a transverse tumour, and branches of the SMA are divided and removed. For descending colon tumours, we do a left hemicolectomy. For an anterior resection is done for high rectal tumours, so the top 2/3 of the rectum, and often a defunctioning ileostomy is done to sort of protect the bowel as it's healing, which then can be reversed in future. An AP, or abdominal perineal resection, is for low rectal tumours, so tumours that are the lower 1/3, or they involve the anal sphincter, and they unfortunately an AP resection always requires a permanent colostomy, because by removing the anal sphincter, that person is not going to be able to be continent if you reverse them. And then a Hartmann's procedure is an emergency operation where a section of colon is removed. So, for example, in diverticulitis that's perforated, we'd remove a section of colon and an end colostomy is made, which may or may not be reversed at a later point. So question number 6. So a 55-year-old woman attends A&E with severe abdominal pain, and she's vomited for the last 2 days. She feels generally unwell, and she's not opened her bowels or passed any wind for 5 days. She's also got hiccups. She had a C-section for the birth of both of her children. What blood test do you think is most important in determining how urgently we need to act?
Okay, we have 75% going for A and 25% for B.
Okay, great. So the answer that I was going for here was A. So what I'm getting at with A is lactate. So yes, arguably full blood count is important in terms of if she's got raised white cells or if she's had a bleed, we might see a low HB, but having a VBG and getting the lactate sort of indicates, this lady likely has a bowel obstruction, but has she got any bowel ischemia? And if her lactate's high, that's going to influence how quickly we need to act and operate. So a small bowel obstruction, presentation-wise, is vomiting, abdominal pain, not opening bowels or passing any wind, and feeling generally unwell or increasing pain suggests further complications, so perforation or bowel ischemia. And the pathophysiology is the bowel becoming what we call mechanically obstructed. So it can be due to a tumour, it can be twisting on itself, it can be adhesional, and any sort of abdominal surgery at any stage carries a risk for adhesions. And sometimes you'll see patients that haven't had any surgery for quite a few years, and then they present many years on with an adhesional bowel obstruction. The fact that the bowel is obstructed by something leads to edema. That edema then leads to sort of problems with the blood supply, and then you're leading the risk of ischemia. And once the bowel is ischemic, it's often not salvageable, and that section of bowel will need to be removed. So often when someone is consented for a laparotomy for this kind of problem, they say plus minus proceed on the consent form, which basically means if we open up the abdomen and the bowel is healthy, we won't remove anything. However, if we find ischemia, we'll remove what we need to. So investigations, bloods, particularly including lactate, and a VBG is enough. Often you don't need to do an ABG in these patients because the lactates will be the same. A CT is required, and then management, get that riles down if they're vomiting, keep them nil by mouth. You can try gastrografin, so giving them gastrografin down the riles tube can sometimes help relieve the obstruction, and it's particularly good for patients who are maybe not fit to have surgery, or if you've got someone that's had a lot of previous surgery and therefore will have a lot of adhesions. We want to really try and avoid going in yet another time and creating more adhesions. So sometimes gastrografin can sort them out without needing surgery. However, if that's not resolving and we're going to go ahead, then it's laparotomy plus or minus resection of bowel. So we've got 2 more questions left. So question 7, 25-year-old woman presents to A&E with severe lower abdominal pain and vomiting. She has got right shoulder pain, and on examination, she has generalized tenderness all across her abdomen, and it's worst in the lower part of her abdomen. So what's the most appropriate first thing to do for her?
Here we got a very quick majority of the answer being C.
Yeah, brilliant. Okay. Yeah, so it's a very quick test. We can get it done. If it's negative, we can move on. But in this case, let's say it's positive. So what I'm angling at here is ectopic pregnancy. So the main symptom is pain, and differentials for suprapubic pain in women include, miscarriage, ovarian cyst accident, including hemorrhage, torsional rupture, pelvic inflammatory disease or UTI. And risks for ectopic pregnancies include previously having pelvic inflammatory disease, having endometriosis, having a IUD as a form of contraception, which very, very rarely fails, but in the rare cases that it does fail, people are at higher risk of getting ectopic pregnancies. Having IVF, particularly things like when someone's had egg retrieval, and having pelvic surgery and associated adhesions in the pelvis. The pathophysiology is implantation of pregnancy outside the uterus, so usually within the fallopian tube, and then once that pregnancy grows to a certain size, it can lead to tube rupture and associated bleeding, which can appear vaginally, but quite often it's just intra-abdominal. And investigations, get the urine dip done. If it's negative, we can move on to other things. Bloods, and then an ultrasound, abdominal, and often TB as well. Management for stable patients is IM methotrexate, and then repeating the HCG on day 4 to 5 to make sure that it's coming down and the pregnancy is ending. If the person's very unwell, or if medical management fails for any reason, then the other option surgically is a laparoscopic self-injectomy, so removal of that fallopian tube. So the last question of the evening, so question 8, a 29-year-old man comes to A&E, and he has got right-sided abdominal pain, radiates from his side into his groin. And he's got no pain when he passes urine. His obs are normal, but his urine dip shows quite a lot of blood. So what is the most appropriate management for him?
Here we've got 75% going for D and 25% going for B.
Oh, okay, interesting. So actually the answer that I was going for here is E. So B would be a good option, yes, to try and relieve some of his pain. CT abdomen pelvis, we'll come on to why we might not do that in this case. But what I'm angling at here is renal colic. So the best pain relief for renal colic is PR diclofenac, and I can't remember why that is, but it's the one presentation where it works better than any other pain relief. And often patients are a bit reluctant to have something PR, but once they have it, it makes such a huge difference. If they don't want that, so that's fine. Oromorph would be a good second option. But as for imaging, for renal colic, a CT abdomen pelvis is not actually useful as a CT KUB, which is a non-contrast CT of the renal tract. So renal colic pathophysiology is stones that form in the kidneys, and they cause obstruction, usually at one of those 3 points, because they're sort of the narrowest. Risk factors include low fluid intake, being male, a diet that's high in purine, so things like red meat, and the presentation is really typical. Sudden onset cramping pain that's typically loin to groin, so the patient feels it in their side and it radiates down into their groin. A urine dip will often just show blood. If there's infection on top of there being a stone, you might also see leukocytes and nitrites. Blood tests hopefully will show normal renal function. If it's showing declining renal function, then that suggests that there might be an obstruction that's causing kidney damage, which can be very serious. And the best imaging to do is this non-contrast CT-KUB. Some hospitals use X-rays still as well, but it's not really slightly out of date to do that. So management, 90% of renal stones pass on their own. So you can encourage people to sort of keep hydrated, give them some really good pain relief, and very often they can go home with sort of a watch and wait advice. Sometimes they can't manage the pain at home and they end up coming into hospital, particularly if it's the first time that they've had this. But if there's any signs of infection or any sign of obstruction, so a declining renal function, then we need to bring them into hospital. If they've got an infection, we need to treat them with IV antibiotics. And then down the line, the way to get rid of these stones is using something called lithotripsy, which is kind of using a vibrating tool going up inside the bladder and up to the kidney and using that to break up the stones. It can also be done again percutaneously, and that's useful for what we call staghorn calculi, so large stones that are stuck in the kidney itself. If someone's got signs of obstructive nephropathy, so the declining kidney function, we need to insert a stent, or if they're infected and obstructed, we do something called a nephrostomy, so an external drain to just drain off that infection and try and preserve their renal function. Just a fact that 80% of stones are made up of calcium. There are other types of stones as well, but that's the most common. And if someone's got recurrent stone disease, it can lead to scarring and impaired renal function. So that's all our questions for today. I'd really appreciate if you could fill in the feedback form. It takes just a couple of minutes, and the slides will be available later on to you guys online, and you can also watch the lecture again on our YouTube channel. We will be doing another session in a couple of weeks' time covering other general surgery topics. And in the meantime, good luck for your final exams, which I believe are coming up soon. And please get in touch with us if you want to ask us any questions.